Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran, and once again, I'm so grateful to have this platform to share it with you, with my dear friends and colleagues, great experts, educators with so much passion to be kind enough to share their knowledge and expertise with all of us from around the world through this platform. As you all know, over the past sessions in this season and also in previous seasons, we try to cover many aspects in implant dentistry, in periodontics, and even in prosthodontics to be able to understand all the rationales behind every treatment, to know about the techniques, to know about the biology, to know about the best proper treatment plan for our patients. And in this season specifically, we decided to be more focused on case presentations and talking all those previous things that we talked about through the case presentations to make it be more practical and understandable for most of us. And our dear guest during this season accepted and joined, and today we have a very talented surgeon and a dear friend, a true skilled periodontalist. Dr. Fadi Hasan is here with me on Hot Seat. Hello, Fadi, and welcome.
Thank you, my friend. How are you doing today?
Thank you so much, and thank you for accepting and joining. I'm pretty sure so many people, those who are followers on social medias especially, are familiar with your beautiful posts and beautiful work, because you are one of those people that really want to share. You know, it's not just about the case presentation, but the time and the effort that you put your cases, you write the description, you go to the details, you answer so many direct messages, I'm pretty sure. So that's passion, and that's, I think, what we need in our profession. And it's not for, I think, not for patients, it's for colleagues from around the world to get an idea, and at least they can see and they can improve their skills and they can get a concept. So thank you for joining. Oops, my microphone went down. For joining and for sharing. It's my honor, and thank you for accepting. Today, the topic that Fadi chose to talk actually is, I think, one of the things that we always should keep in mind, and that's thinking biologically in treating our patients. So many speakers also talked about it in different scenarios, but it's the reality, because sometimes we prefer to do what is easier for us, what is preferable for us, but not what is right for the patient. And today, before we start recording, Fadi told me about the cases that he wants to present. It's about multidisciplinary approaches and how we can achieve the most predictable outcome for our patient, for the patient's good, not for our time or our preference. So it's interesting. Definitely after the presentation, you will get so many ideas, and for sure we will have a great discussion on the topic. But before we start, I would like to have Dr. Fadi Hasan's CV for all of you. I'm pretty sure most of you know this guy, but as a tradition of Hot Seat, I would like to have his CV, and then we will go to the presentation immediately. Well, Dr. Fadi Hasan received his BDS degree in 2007 at the University of Baghdad College of Dentistry, and then University of Colorado School of Dentistry, he received his DDS. Also, the certificate in periodontics and implant dentistry from University of Virginia, Commonwealth University School of Dentistry, the degree of MSD. He has also he's active as an assistant clinical professor at Virginia Commonwealth University, also from 2016 till now, and he's the diplomate of the American Board of Periodontology and Surgical Implant Dentistry. As I told you, he's with a bomb of inspiration and passion in this profession. I'm a periodontist, and it's totally understandable for me, at least, and I'm pretty sure for all of you. So I'm pretty sure during the case presentation, you will get what I'm saying now. Fadi, again, it's a pleasure, and the platform is all yours.
Thank you so much, Omid, for inviting me. I've been watching your Hot Seat since season 1, so I've been very excited about it. And of course, every person you've had has been, one of the most inspiring surgeons out there as well. So hopefully today my presentation will be something just as inspiring for a lot of our colleagues. And like you said, as periodontists, we do have a lot of passion for what we do. And hopefully today what I'll show you is my passion for this field and the beauty about periodontics. So I will start sharing my presentation with you. All right, let me make this bigger. 1 second. Oh, here we go. All right, so my topic today is about just thinking biologically, and like we mentioned, there's going to be several cases that I've had a great opportunity to come across me through the last few years. Some of them will be my experience from when I was a resident, how I treated it at that time, and up to maybe 6 months ago on some of those cases. So just the idea about what we can do really for the best interest of our patients. And sometimes they will get different opinions about different treatments. I do believe at the end of the day, it's providing them the quality that hopefully they deserve from us. So my first case, which I'm going to just kind of jump into, and I'll throw in some literature as I go in through the way. But this was a case, one of my early cases in residency, and something like this that presented to me at the time was a localized kind of vertical defect, what we see in residency all the time. Probing anywhere between about 10 to 12 millimeters. So as when we first kind of learn about perio and how to address periodontal disease, we always want to look at some etiological factors. Well, what caused this? How can everything look so great in the patient's mouth except this one area? So looking at this, what we do see is there's a slight open contact. There's a little bit of, it looks like a little bit of suppuration coming out. And I'll get a chance to also show you the x-rays and how things sometimes can look really deceiving on a two-dimensional image versus a CT scan. So, we reflect the flap and it looks something like this. And I'm seeing it's like, okay, that looks really weird. The bone is slightly expansile. It's been expanded over the last maybe 6 months, maybe a year. But what amazing is that this tooth is absolutely vital. We checked it for vitality. And we'll show you the x-ray at the next slide. It's like, okay, this tooth looks really great. So I had my endo colleagues at the residency at the time. They do the vitality testing as well, just to make sure I'm not missing anything. So we opened it up. Again, I do apologize for the pictures. This was early on residency, so a little bit kind of bloody and messy, but things will get better. So when we look at the x-ray, this is what it looks to us. It looks like there's some form of, an intra-bony defect developing, slightly radiolucent on the mesial aspect of that, the first molar. I think you say lower 6 I guess in how we'd say back in the Middle East at the time. So I get a good aperture and we go in and kind of rotate. So looking at this is like, okay, looks like it's a well-contained defect. I'm not sure what it looks like. A possible root fracture, we don't know. So we do all the tests with it, then we decide to take a CT scan. So on a CT scan, it looks something like this. There's a very well kind of localized defect. And what's amazing about the pictures on the left is that bone looks like there's like an onion kind of shell type of appearance, like it's a slight expansile type of lesion. Mind you, the tooth is still vital. So something I learned in residency was get an explorer, and when you open the flap, and you get to the bone, kind of puncture it, and that's what endo residents do when they perform their apicoectomies. Just can't help them see, where the soft lesion is of the bone. So it's pretty much what I did in this case. So, it looks something like this, and I'm looking just like, wow, that's like a 2-wall defect, from a GTR perspective, if we can save it. Again, the tooth is still vital, despite the fact on the CT scan shows it goes way beyond the mesial buccal root on this case. So kind of give us a little bit of idea about, what GTR is. Our goal is we want to prevent epithelial migration, exclusion of that epithelium along the cemental wall of the pocket, and we want differentiation of new cells, which is cementum, bone, and PDL. That's our always goal. So early theories by Melker in 1976. Again, since we both are teaching, so just to kind of bring back some old classic literature, Basically carotid root surfaces, they can either be repopulated by epithelial cells, which we know is a long junctional epithelium, sometimes connective tissue cells, sometimes bone cells, and it can result in ankylosis of those roots, and sometimes just periodontal ligaments. So we really would never know unless we do a histological finding after every GTR we do. But at least it gives us an idea of what kind of population of cells that happens when we try to curate a root surface. So going back to the early studies, by Bowers in 1985 to 89, which is we call them the henna studies, and they looked at all these kind of different ways to see what kind of cell repopulation do we get. So if we had a defect that was non-submerged and non-grafted, means that it wasn't covered and wasn't grafted with bone, we would see epithelial cells will grow into the defect. However, if they decide just to cover it with a submergent, we just cover the barrier membrane possibly, or just the tissues itself, you'll see some form of connective tissue attachment. They decide, well, what happens if we just grafted it with bone, but we don't submerge it, we don't cover it? They found actually there was about 60% the chance of regeneration of that tissue. With the combined submerged and grafted sites, which means that it's been bone grafted, it's been closed up, all that, you will possibly see 90% of regeneration potential. So those were the very early studies, from 1985, or even before that, by Bowers and Melanig and Murphy and Gonzalez, all those early studies about comparison between GTR and open flap debridement. So it's gone a long way over those years. And especially now with adding biologics to the equation of guided tissue regeneration. So what are the defects that we know? From 1993, Cordellini, those are one of his early studies as well. He showed that 3-wall defects have a 95% chance of fill versus a 2-wall with an 82% fill, and a 1-wall with a 39% fill. And also he found that if the angle of the defect of the base was more than 25 degrees, the likelihood of regeneration is also less. And a great one also by Tal, he found that if the distance between two adjacent teeth was more than 3.1 millimeters, sometimes you can actually see 2 infrabony defects. So these are all things that actually we do see, and every now and then. And it does show a lot of truth as far as the outcomes that we can predict for our patients when we start to performing those surgeries, and how we can really save those teeth for them. So going back to our case, this is what it looks like when we, after it's been debrided, it's been cleaned really thoroughly. So working with my endo colleagues, I got, methylene blue. I dyed the root surface just to make sure that there's no vertical fractures that we were missing in case we missed something on the CT scan. So we clean it, debride it, we don't see any stainings after that. So after we do a thorough cleaning, then we start using, prep gel or EDTA to remove all the smear layer. And then we decide to go, with freeze-dried bone allograft. Now, this is a case where I decided to use GEM21, which is platelet-derived growth factor, the recombinant one. So we mix it with the FDBA. Normally, we have to at least soak it for a good solid 10 minutes. PDGF is an amazing growth factor, it enhances a lot of, as far as cell migration, chemotaxis to the surgical side, allows them to induce hopefully new bone formation and also new regeneration. The studies as well have shown that in comparison of using growth factors like GEM21 or MDGAIN, they found really comparable results as far as regeneration compared to just your standard GTR with bone graft and membrane. So in this case, usually we like to use membranes to cover our bone graft. But for the purpose of using GEM21, they always recommend without any barrier membranes for exclusion. So we just decided just to completely close it up as it is. So and again, going back GEM21, what is it exactly? Well, it's a growth factor enhanced matrix. And the reason 21 comes from, it's just from the 21st century. That's literally the whole idea about 21. So again, it's a recombinant platelet-derived growth factor. Again, it's always in a osteoconductive matrix, which is a beta tricalcium phosphate. Most of the time, we rarely use it. Just the TCP, we can tend to use mostly, like allografts or xenografts for the purpose of it. So again, what does it do? It stimulates chemotaxis, like I mentioned earlier, which directs specific cells to migrate towards a surgical site. Mitogenesis, which allows for new bone and periodontal ligament formation and proliferation. Matrix formation as well, which is collagen that we all need, of course. And angiogenesis, which is new blood vessel formation. So whatever we can do from a biological perspective to improve the wound healing and the quality of the regeneration is our end goal to really achieve those really good long-term results. So again, the other practice factors about it is that it does speed clinical attachment level gain. It's also been shown to reduce gingival recession and improves bone growth, resulting in increased bone fill. So just gives you a little bit of idea what GEM21 is and what does it do from a regeneration perspective. So this is a PA that I took of this case. Surgery, which is on the left side, 6 months follow-up on the PA. So we can see some really beautiful bone regeneration that's been happening at 6 months. Now the question is, will it last long? So the key thing is we need to still understand the main etiological factor as far as what caused this case to start. So amazing, 6 months later, this patient still has not closed her contact. That was still the main etiology. However, she was doing a much better job in keeping this site really nice, healthy, and clean. Well, what does it look like at 1 year? And then that's when we decide to take another CT scan just to see, well, does the defect look exactly the same what we saw early on with that huge, blown out aspect. So this is a 6-month follow-up clinically, what it looks like. So the tissue looks beautiful, mature. She can definitely improve her home care at this point in time, but just to see that there's nice wound healing and everything's really nice and, closed and really well tight. And the gums just look pink, healthy overall versus, it was kind of, there's a lot of suppuration at the early phase. So again, the contacts have not been closed yet, but that's something that she definitely needs to do to help hopefully prevent any food impaction or food accumulation. 1 year follow-up, it looks like this as well. So still healing. She still has not closed a contact, surprisingly, even despite the fact that we keep encouraging her. Now, usually my patients, after doing any kind of guided tissue regeneration, they are on a strict maintenance protocol. And we both know as periodontists, the key to success to any periodontal surgery is maintenance, no matter how good our surgery is. And that's something if you, for example, if you visit Cordellini in Italy, and he will literally hoard his patients for a full year and just to make sure that he really is on control of their periodontal maintenance until he maybe starts even doing a procedure on them. So that's something I started doing as well, is like, I'm going to keep my patients for a full year after the surgery, just to make sure I can maintain them properly, that no one is disturbing the healing aspect until the patient transitions back to their general dentist and get things addressed. So again, 1 year follow-up, what does it look like on the CT scan and bite wing? So again, you can see some really beautiful regeneration of the bone on the mesial aspect of that first molar. She lost a tooth on the top in that process and she got an implant there. But it's nice to see how well dense that bone is. And if you remember the CT scan, the 1 year follow-up, it looks, that bone that was completely lost on the buccal with that onion shell, it has been literally fully regenerated all the way almost up to the CEJ, or at least 2 millimeters below the CEJ. So it just shows really the power potential of biologics and respecting the body to heal and taking its time. And really key thing is to maintaining those surgical outcomes that you do. So 1 year follow-up, beautiful healing, beautiful regeneration, tooth is still vital. And again, she never closed her contact, despite the fact all our efforts to make sure she closes it so we don't get any periodontal disease kind of coming back again. So one of the early cases that I did in residency, and I was very pleased to see something like this, like, the power potential of adding biologics to your guided tissue regeneration cases and really achieving results like this. So that was, again, one of the early cases on. So again, this is the CT scan. Again, this is, again, pre-surgery on the left versus the 1 year follow-up on the right side. So again, beautiful regeneration potential and kind of having that growth all the way back again. So a beautiful comparison. Sometimes it's really hard for us to have the patients come back at 1 year, especially during residency, and being able to take a CT scan like this and really have a nice comparison. And I've been asked a lot, why don't you publish this, this case series? I was like, it's an N of 1. It would be great to have more of cases like these, but just to kind of see something like this was really fascinating. For a second or third year periodontal resident. This was maybe almost 10 years ago. So just kind of show you one of my early cases on. Now, another case which I was actually just been treated very recently was this case. This case was actually one of my early cases, and also in private practice. That patient came to me. I did actually a connective tissue graft on this tooth, and then she kind of disappeared. They didn't come back until I found out that she went to one of my ortho colleagues in the area that I work in. So post ortho, he sent her back to me maybe about 6 months post ortho. So I was like, hey, listen, man, there's a lot of food buildup here. Can you please address, this? Maybe she needs a soft tissue graft. There's some recession. The tissue's not great. I didn't have any pictures as far as, x-rays to show you for this case. But what was amazing to me in this case, Omid, was on the x-ray, it looked nothing like what I'm going to show you on the next slide. I reflected it and it looks something like this. And I'm seeing this and I was like, oh my God, this is going to be a very interesting and challenging case to look at. So what I do see is, you can see the roots of the adjacent teeth, both, at least on the mesial aspect. Same thing goes for the tooth next to it. Amazingly, this tooth was still vital, after all this bone loss. So I get with my periodontal probe and I'm literally going and I'm feeling the lingual surface, and there's no bone on the lingual surface. It's just purely soft tissue. And the root is literally hanging by maybe 1-2 millimeters of native bone at the apex, not more than that. So, we look at these cases and we try to think, well, what is the best way for us to manage this case? Now, mind you, her brother is a dentist in a different country who had recommended for her extracting all her lower teeth and giving her an all-in-4. So when she told me this, I was like, give me like halftime. This doesn't make sense. That's too much of an aggressive therapy. I was like, I want you to give me the chance, see if we can really save this tooth for you. So, my plan was to do a free gingival graft. And when I was thinking about this case, when I cleaned everything open, it's like, well, if I can maybe continue with my plan of doing a soft tissue graft first, so at least I'm achieving a healthy soft tissue to start, and then I can maybe come back later, and then I'll do some form of guided tissue regeneration. And maybe I can help regenerate that bone once I have some soft tissue that I can actually maybe advance, I can reflect, I can actually suture again. So it's the big question that always comes to us is, we need to really think what the end in mind means, that I can't do a bone graft here if I have nothing to close it with. And I'm seeing more of those cases related to orthodontic therapy. They look exactly like this, or sometimes less severe than this. So I am starting with the ideas like, I'm going to perform a soft tissue graft first. I'm going to achieve whatever amount of keratinized tissue I can. Then I'll come back maybe 2-3 months later, and then I will start doing my either guided tissue regeneration, either by itself or sometimes even in combination with a soft tissue graft, so I can improve not only bone healing, but also soft tissue healing simultaneously. So I treat the root surface with EDTA, Prev gel. I added Emdogain, which is another growth factor that we also have in our armamentarium. So, it's an enamel-based protein made from porcine tooth buds and has incredible regenerative potential, especially for cementogenesis, to be specific. So I add the Emdogain and I followed it with a free gingival graft. That was my next step. And decided I'm just gonna close it up. Let's see how we respond, how the body heals. I told her, and I told my patient, I was very honest with her, I was like, this may work or it may not work at all, but it's better than just going full mouth extractions on your lower jaw. Let's just start with a 1 tooth. Worst case scenario, if it doesn't work, then we can talk about maybe removing 3 teeth and having 2 implants in the 2 laterals with a 4-unit implant bridge as a potential. But let's just be conservative and have some trust in me. And luckily, she did have that, and we went in that direction. So, what does it look like at 6 months post FGG? It looks something like this. So what I do see is there's still some plaque buildup. The papillas are still intact. Yes, the soft tissue is there, not the best quality, keratinized tissue. It's still inflamed, but not as inflamed as it was in the past. So I'm looking, I was like, okay, there's some hope. So now for my re-entry, it's like, okay, now I'm going to decide to do maybe a lateral sliding pedicle with some connective tissue graft, but I really don't know what's underneath it. Radiographically, it looks normal. It doesn't look blown out as it was. So what does it look like at re-entry? It looks something like this. I was actually able to regenerate bone on the adjacent teeth. So none of those mesial roots were showing just by simply adding emdogain and closing up with a free gingival graft and just letting the body and the biologics really work its way and using the right materials for it. So if anything, I have bone regeneration all the way through the lingual plates. My probe does not go to the lingual plate anymore. So now that doesn't mean I don't have a vertical component or like an intrabony component. There's still some there, but in comparison to my first picture, it's a major improvement. So same protocol as last time. It's like my goal is I'm still going to do a guided tissue regeneration approach. So add an emdogain just to increase the chances of it, the survivability and improve the cementogenesis and the periodontal regeneration potential. Added an FDBA, which is a freeze-dried bone allograft, into the defects themselves, and also on the facial. And then I decided to add a connective tissue graft wall just as my barrier membrane. So I use that and I sutured it with 7.0 PGA or 7.0 Vicryl versus using a membrane. The reason I decided to go with that because I designed my flap as a lateral sliding pedicle, and I wanted to improve the thickness of the tissue, the quality of the tissue. And I wanted also adequate blood supply to my connective tissue graft versus having a barrier membrane and a connective tissue. I was worried that I might lose more of that blood supply to my connective tissue graft. So immediate post-op, it looks something like this. Close it up with 6.0 nylon sutures. There's some periacral on the sides just to make sure I have literally almost complete closure of the wound. Now, this is your pre-op, if you remember. This is the 6 months post-FGG. This is your 6 month post your GTR and your connective tissue graft. Now, this probe's about 2 to 3 millimeters. So we went from a case where it was almost 10 millimeters of probing and no palatal, no buccal wall, no interproximal bone as well, to something like this, where you have healthy tissue. Do I want more root coverage? Yes, absolutely. As a periodontist, we're always anal. We always try to be perfectionists as best as we can. But at this point, this patient's just like, I've had enough with gum surgeries. I need a break. So just let her, take her time and hopefully we'll be able to come back and touch it up at the very end just to improve that root coverage potential. But it's amazing to see how, just respecting the body heals and sometimes not being too aggressive by going extractions or major ridge augmentations or full arch cases that was kind of, planned for this patient, but letting the body heal, just using the right materials, from autogenous to biomaterials to biologics as well. And, and just letting that work, let it do its work, and the regenerative potential of that happening. So again, one of my really fun cases, and I wasn't expecting to see a result like this, but again, very happy, the patient's happy. And finally I gave her my blessings, it's like, everything's been healed nicely. You can finish your orthodontic therapy and, kind of continue with our life. So again, one of those, I think, definitely more inspiring cases for me. I know it's a single tooth, in other words, but sometimes single teeth can make a difference for not just you, but also for the patient as well. So that was kind of the end of this case. And hopefully I'll see her again for the future outcomes and see how she does heal and maintaining that for long term as well. Now, moving on, again, I promised you different cases. So this is another completely different case we're going to be talking about. So the first two cases was a guided tissue regeneration, perio, endo, and then perio ortho. This one was perio and working with oral surgery. So this was actually referred from an oral surgery. This is a 25-year-old gal who is young, very beautiful, who's had several traumas, in her front teeth. The first trauma when she was a really young lady, and by about 8 or 9 years old, she had some RCTs that was performed on her central incisors. Then fast forward almost 20 years later, she literally had another trauma in her front tooth and lost her front tooth. So what resulted was, her primary general dentist extracted the tooth, did a bone graft, it failed, did a second bone graft, it failed twice. So now that's 2 procedures. At that point in time, she decides to see someone else. So she goes to an oral surgeon who honestly did an amazing job with the regeneration potential, because she had lost significant amount of bone vertically and horizontally. So he did the sonic weld technique for the regeneration, and he gained some beautiful, horizontal ridge augmentation as well as some vertical. So this is what she presented to me. At this time, she's had 3 bone augmentations. And also the 4th surgery was when she came to me, her implant was already placed by the oral surgeon. So, from my perspective, if something would be referred like this to me, I would like her maybe to go to ortho first, see if those lateral incisors can be intruded again, because they have been extruded as well from the trauma in the past. My understanding from the patient is that she declined ortho at all, like she didn't want to do it at period. So I think that also kind of resulted in the compromise on the outcome of this patient, as far as what it looks like at this point in time. So the oral surgeon requested one specific thing from me. He says, hey, listen, Fadi, the implant is in, I've done my bone augmentation. Can you do something to improve the soft tissue? Now, again, this is a case where there's been supraeruption. The patient has had already 4 surgeries by now, including implant placement. I'm going to be number 5 to do some form of soft tissue therapy. Now, you need to think about how much scarring there is at this point in time, how much bone graft material there also is in that soft tissue once you reflect it from the previous 3 bone grafts. And that's exactly what I encountered when I was doing my, when I was releasing my flap and reflecting everything. And I had to be very careful at the same time, because the implant was placed 6 months ago and now it wants to be restored. So I was thinking, okay, what's the best way to actually start achieving possible some form of vertical gain in soft tissue? So it was actually Zukel who had a really nice article, the tabletop technique, that he published a few years ago, where he adds 2 layers of connective tissue graft, one facially and one on the vertical aspect. So that was exactly my approach. So I did everything as a partial dissection, cleaned the roots, applied EDTA. I used my first layer of CTG, and this is a de-epithelialized free gingival graft. So first layer is on the facial, and then I put a second layer, facial also occlusal, and then I closed it up immediately post-op, and I did a small frenectomy to kind of minimize the amount of pull from the frenum. So I closed it up. It looks like this at the immediate post-op. He was like, okay, hopefully it stays something like this. But realistically speaking, her bone levels are still way far up apically. That's not because of the supraeruption of the teeth, the history of the trauma, the multiple bone grafting surgeries. So again, not ideal, but this is what we were able to achieve on the day of the post-op surgery. Now, what does it look like at 4 weeks? This is what it looks like at 4 weeks. So I'm looking at this, okay, my lateral and my central on the facial, it looks much better than before. Interproximal, not so much. So the question is, did it open up during the first 4 weeks? Possibly, it might have retracted a little bit. Possibly the connective tissue got a little bit exposed, so it's in the keratinization process. So fast forward, this is what it looks like at 4 months. Again, a little bit of retraction that was done. At this point, the patient, I told her, we can try and do a second soft tissue graft. I don't promise great results. If that's what you want me to do to really improve it, or we can have the oral surgeon work with a prosthodontist, and they can maybe start designing new prostheses for the lateral and the central, and see if they can lower the contact points and cover some of those roots. So she decided to go with option number 2. So I haven't seen her yet, what the final outcome looks like. I think she's at this point almost restored by this point in time. But at least from a soft tissue management perspective, this is what it looks like when she went back to her oral surgeon to perform the second stage. And I had the opportunity to actually talk to the prosthodontist, and I told her, can you please just make a provisional implant crown and see if you can at least try to create that emergence profile for her, and also adjust the contacts and adjust the provisionals on the adjacent teeth, so she has a better, more aesthetic appearance. So hopefully they were working on that and try to get her to that level. I've been trying to follow up with a patient, but she's not really easy to get a hold on to. So I haven't been able to see her, what she looks like today. I'm hoping that she's been fully restored by now and, enjoying her beautiful smile. So we'll see. If I have a chance to see her, I'll definitely post this case on my social media, and that way everyone can also see it for the future outcome. Now, another case which was interesting as well, this is now switching from GTR to connective tissue to now going to more of a ridge augmentation case. Again, another interesting case that was referred here, but this time this patient had an implant as well, failed, had a ridge augmentation that also failed, and then they decided to go with a connective tissue graft to improve the buccolingual dimension. So at this stage, I don't know what's really going on. We take a CT scan, but I'll actually show you the re-entry because it's way more interesting than what it looks right now. But if you see something like this, I'm thinking, wow, she looks like she has a lot of bone we can work around with. That's really thick buccolingual dimension. I might even be able to place the implant for the sake of the argument. But what was interesting is, again, that's your facial, just to have an idea what it looks like on the facial shot. So again, pre-op, that's a 6-month post-op surgery, but I'll able to show you everything along the way. So this is what it looks like when we open it up. It looks something like this. So it's like, okay, wow. So you can see some bony particles, like some of the allograft and the xenograft during the ridge aug, the small pinpoint particles. But honestly, clinically, it looks so much different than it is, pre-surgery. Like you can see, there's so much soft tissue thickness, but none of the bone width that you would sometimes expect to see. So that's where the CT scans come in really beneficial in kind of seeing the severity of those cases. So when I think and when I see something like this, again, thinking biologically, what is the best treatment outcome for this patient? She's had an implant fail. She's had a ridge augmentation that failed with allograft, and she's also had a soft tissue graft. So the question is, what other materials are there? Can I do another allograft ridge augmentation procedure? Yes. Can it work? I'm sure it can. But from my personal experience, what I've seen is, and even with my own cases, some of the cases where I've treated once or twice with allograft surgery, if I'm doing it a third time, most likely it's not going to be as successful at all. If I've had 2 failures with a previous allograft or a xenograft, I'm sure the third time is not going to be any better. So for the sake of this case, and from my previous experience and learning from your own mistakes, which is really key, I decided to go with the 40 plates. So basically I harvested from the ramus, used 2 40 plates, one on the crest, one more apical as well, and then fixated with screws. And that's the 6-month re-entry with 40 plates. So beautiful bone regeneration. Again, just thinking 100% autogenous bone grafting material, and then just allowing the body to heal naturally using the patient's own bone. And just from a biological perspective, we know that autogenous tissue is always the best. It's amazing how many great products out there from allograft and xenograft, and for bone grafting or even soft tissue grafting. But at the end of the day, just autogenous tissue tends to have the best outcome, honestly, than anything else I've seen. So I think from now being in private practice, I'm definitely seeing myself switching my gears more towards autogenous tissue than towards using allograft. It doesn't mean that it doesn't have its applications for other products out there, but autogenous just seems like to be the material of choice and that makes more sense. And especially those compromised surgical sites where it's had more than one surgery in the past and it's had some failures and they've not been working well. Autogenous does seem to be, the best choice long term. So 6 months, this is what it looks like: beautiful native bleeding bone. And then we just simply go with our implant placement. So we place our implants, our Straumann 3.3 at this point in time. And I do like the concept by Luca Di Stavola and Dr. Tunkel, where they published in 2013 in JOMI, about kind of adding another layer of allograft with the membrane following GBR procedures, especially for cases with the autogenous grafting, just to make sure that there's minimal turnover for the autogenous plates. So I did use an allograft here and a membrane, and I closed it up. So she's in the healing process now. So hopefully within the next month or two, I should be ready to perform my second stage with a provisional implant crown to allow that soft tissue healing and molding. So again, this is your occlusal, your facial shot. Again, your implant placement, 3 millimeters, from the CEJ. Each dot represents that. And then again, your immediate post-op. So nice vertical gain of the soft tissue, also horizontal gain. And the next step is to just kind of really recreate that emergence profile and get things as natural as possible for our patient. And hopefully she'll be happy. Again, she's a young patient. She's had already 3 surgeries before. I'm being the number 4 at this time. So hopefully the goal is, what can we do to really improve the long-term quality and the longevity of our treatment? And again, thinking biologically and just using autogenous tissue really helps us get to that level that we really are achieving. So again, very happy with the outcome. All right, and the last case, and then we'll be able to dig into questions and answers. So another case which I also referred, this is actually a guy who's 38 years old, had his implant exactly when he was 18, 20 years ago. He was on vacation, and all of a sudden, implant falls out of his mouth, out of nowhere. So he presents to me now. I see him literally maybe about 1 week after the implant had failed. And I go, listen, man, I need to wait for things to heal. Let's just allow the soft tissue to heal. Let's allow maybe some of the bone to heal. And then we can go in and we'll do a ridge augmentation. So re-entry, there's severe facial loss, and there's also palatal bone loss. So this is more of like a vertical defect, and this guy is 38. He's young. So that means he still wants to have a really good smile in the future, and not something compromised with a significant defect. CT scan, this is what it looks like. So that implant that was infected, it blew out through his floor of his nose. So it literally goes all the way from the oral cavity through the floor of his nose. So a really severe type of defect with also, again, severe facial and also palatal bone loss. So this is a case where it's like, can I do something just using, allograft with a membrane, titanium reinforced? You start thinking about all the different options available. Now, my personal experience, I haven't had the greatest success with using titanium reinforced membranes, so I kind of shied myself away from it. I do like to use more either autogenous 40 plates. Sometimes I'll use the bone ring technique for specific anterior cases, by Straumann bone ring or Botis as well. That's worked really well in my hands in the past. So, but a case like this where there's too much vertical as well as buccal and palatal, I was like, let me just go autogenous. Let's go 100% native bones and see how the patient heals. So this is our surgical approach. We take a piece of ramus block graft from the palate. We cut it in half. We fixate it buccally, palatally. We remove the nasopalatine canal, clean it out very thoroughly, and then we just dense it and compact it with autogenous bone. I added a very thin layer of DFDBA on this case, just on the top, just to protect it. And I did cover it this time with a barrier membrane, just because I know the extent and the severity. And then I did a VIP CTG. vascularized interpositional connective tissue graft, just so I can add another protective layer. So I can really improve the vertical soft tissue healing as well as the facial as well, just to act as another protective barrier. So we closed it up. It looks something like this on the left. This is the 3-month follow-up. So I haven't gone in for re-entry yet. I think next month is due for re-entry. But I love to see how much bone, how well it's healing with autogenous tissue. Thinking about using your FORU plates or adding a VIP CTG or connective tissue graft to your ridge augmentation procedures, and really allow for better wound closure and the chance of better regeneration, I think is the end goal. So again, this is what it looks like before. This is just a 3-month post-op. So again, major improvement in the vertical height that we see already. So that means going in at the 6-month re-entry for vertical augmentation, or at least a sandwich technique, it does show that it has a really good regenerative potential. Now the occlusal shot, I always like to take pictures from 2 different angles, facial and occlusal, because it really helps you see the extent of the defect. So this is what it looks like on the pre-surgery and immediately when you open it up. Again, big defect. And this is 3 months after we let him heal when he lost his implants. So still there's a significant amount of bone loss that he has. So again, these are your 40 plates. Again, that's our nasopalatine canal cleaned up all the way. And then just using 2 fixation screws for the facial and 1 for the palate. And then really filling it up with, again, autogenous and also with DFDBA, and then covered with a membrane and then with a VIP CTG. So your immediate post-op is on the left, as you can see in your 3-month post-op on the right side. So again, the next point in time is re-entry. So I think we did this procedure, was November of last year. So literally next month is going to be May. It's going to be the 6-month re-entry. We'll be able to hopefully place his implant in a nice provisional, or maybe just bury it depending on the quality of the bone that we see at re-entry. So, again, pre-op, 3 months later, definitely improvement compared to what we see. So that can help give you a good presentation of 5 different cases that we went through, and just kind of between GTR cases versus a soft tissue graft versus FORU plates. And I think like I said, different biological aspects, autogenous versus adding growth factors, and using connective tissue as one of the things which has really gotten increased more with almost every regeneration potential that we've been doing recently.
Exactly. First of all, thank you, Fadi. It was amazing. And I want to thank you especially for bringing GTR cases in the presentation, because this is something, generally speaking, sometimes some practitioners forget about the possibilities of treating the patients, in this aspect. Not as a periodontist, no, but as a general practitioner. And I've seen it in my country, at least, that so many of these teeth that can be easily treated periodontically will be extracted.
Absolutely.
I learned this from so many of my mentors. They've always said it, that it's really easy to convince the patient to extract the tooth or convince the patient to save the tooth. But only one of those decisions are the right one. So it's really important to really know about the possibilities. So to all the audience watching right now, this is not something by chance. This is biology, and this is based on a good diagnosis, good treatment planning, good execution, and you can easily save these teeth. And even with worse scenarios, as you saw in the second case. So we will talk about it. So Fadi, speaking of your first case, GTR, you showed that you found the shape of the defect even before opening the flap, and you decided to go with the graft material. You used allografts and did it, because I usually personally do the allograft to the mineralized one. And I noticed that you didn't put any membrane on your graft material.
Yes.
Because your defect was kind of contained in the half of apical part of it and non-contained on the top.
That's correct.
Yeah, because some practitioners prefer to put the membrane. Actually, me personally had some studies, and we used connective tissue graft as a saddle from the buccal to the lingual to prevent the collapse of the papilla. So you achieved a brilliant result. But I want to know, is it your preference generally, or in this specific case you didn't put membrane? So I want to know your concept on using membrane in such cases.
So for the first case, based on my understanding from, and again, I did this case in residency, is that when we first got our hands on, using GEM 21, is that the protocol is not to use any membrane at all with guided tissue regeneration. And again, the studies by Nevins that was shown, I think it was in early 2009, if I'm not mistaken, with the beta tricalcium phosphate and using GEM 21 for regeneration and the different concentrations. And all that was a multi-center study as well. I think it was about 182 patients or 187 patients at the time that they did. Their idea was that not using any membrane at all. It's supposed to be because the GEM 21 as a biological material was supposed to prevent any epithelial migration. That's, again, this was from, again, I'm going to say this because it was back in residence.
Yeah.
So today, do I use membrane? Yes, I do. I do believe that adding a membrane is a very key factor. And for all my guided tissue regeneration cases, I do use Emdogain, I do use a bone graft, and I do use a membrane. But for this purpose, because again, when you're in a residency, your program director is always like, you have to follow the protocol. So the protocol was to just use, again, this is a combination type of defect. This is a 3-wall at the bottom and then becomes a 1-wall on one side and a 2-wall on the other side. So it's a really interesting combination defect. So again, we added just FDBA, which is the freeze-dried bone allograft. And this is I think it's a 70-30 cortical cancellous. And then just add it's soaked in the GEM 21 and for like 10 minutes, and then we added and we closed it up. Have I been using, you mentioned a great point is, have I been using a connective tissue graft as my wall? Yes, I have, especially my interior cases. I don't use a membrane on most of my interior cases. I like to use the CT wall, also described by Zucchelli is one of them. I think, I'm trying to remember the other article that was also published by using the CT wall instead of a membrane. There was a Trombelli, if I'm not mistaken. I'll have to look back into my old articles as well. It was published maybe 2006. And the JOP, and they also looked at using just a connective graft wall by itself and with Emdogain only as for regeneration, and it's also shown some phenomenal results. So in interior cases, I love using a connective graft, bone graft, Emdogain, and just closing it up from an aesthetic point of view as well, to make sure we preserve that the papilla, and make sure we don't have too much collapse. Because one of the most consequences of any kind of guided tissue or osseous resurgery is always recession. And patients tend to complain a lot of time it's sensitive in that area. So if we can add that connective tissue wall to improve also root coverage and thicken the phenotype and make it less compromised for future recession, put it in. It's not going to hurt the patient. Just thinking biologically.
Yeah, Fadi, the reason that I asked about the membrane, in this case, the root surface is in the bony housing. So, so the reason I asked that if you want to do this case again, you mentioned that you prefer to use the membrane, but the point that I want to make clear here is this. What if we don't put the membrane in these cases that the root surface is in the bony wall? So do you think that if we don't use the membrane in such case, the result's going to be the same as if we use the membrane? Or you think that definitely using the membrane without using any GEM 21 or extra anything,
I know. I do believe in membrane as an epithelial exclusion. I do believe in the power potential of having that membrane. I mean, we know that soft tissue grows faster than bone. So having that occlusal barrier to prevent epithelial migration and connective tissue formation, to hold it while that bone graft that we added there to aided in helping it kind of do the blood clot formation and the mitogenesis formation and the osteogenesis formation. That's the key. I think the membrane as a barrier is really key in epithelial exclusion. I mean, that's from the.
But what about the morphology of the defect? You know, because here, you know, it's like a tree wall, as you said, it's like a tree wall defect in the apical part, and only in the crestal part, in the interproximal, it looks like a one wall defect. So do you think in the apical part, the usage of the membrane is necessary to achieve the bone?
No, if it's a three-wall defect, the apical part, I don't believe so. No,
Yeah.
I agree with you on the same page. I agree. Yeah.
And,
I agree 100%.
and if you want to go back to this case, I just want to make this clear for the audience, because I think sometimes they get some information during the discussion. So I try to make the questions in that way. If you want to bring a single etiologic factor for this defect, what would be the most proper etiologic factor for this kind of defect in this case?
This one, I really believe was an open contact.
Open contact, yeah.
Yes, I mean, that is an etiological factor, because you're allowing food and plaque to be literally pushed inwards towards that defect, and with time, and now you're having all the pro-inflammatory processes from the plaque buildup. You're having now bone resorption patterns, you're having inflammation, you're losing collagen content in the area. The area of that tissue becomes, it's less, not as strong as it was before.
Yeah.
Meaning that you're allowing more bacterial infiltration into that defect site.
Exactly.
So that is the main reason for this, which is why we always encourage close your contacts before any GTR. You know, this case, again, this was a great learning experience, because, you know, I did my examination on this case, and the first thing my professor asked me is like, why didn't you close the contact first?
Yeah.
And he's right. Should have been closed first before I even started this case. The patient didn't want to. I was like, please do it. And 1 year later, she still didn't close it. Amazing. Yeah. It's like, they don't learn sometimes, you know? But yeah, I think open contact would be the main etiological factor in causing something like this, and just the plaque buildup and the calculus buildup over time.
Yeah. And you know, regarding your second case, the ortho case, that you had the whole length of the root exposed. First of all, what's the question for me is that, is this tooth mobile, or is it become immobile with the brackets?
Immobile because of the brackets.
Because of the brackets. So if the patient, so the question is this: sometimes patients come to you without having any brackets on, and you see the mobility. Will you take the same decision by splinting the teeth and do the same treatments or not?
If there's any mobility, and if the patient asks me specifically, can you please save my tooth? Two things I will do from a periodontal perspective. Number one, it starts with the SRP and splinting and occlusal adjustment.
Yeah. Yeah.
That's very key. You want to minimize trauma from occlusion in any way to improve the regenerative potential. And the reason I'm saying this, because studies do show regeneration is less effective when there is hypermobility with the teeth.
Exactly.
I know this. So a case like this, the tooth was not mobile because the patient has been in ortho for a period of time, and the orthodontist stopped her movement completely. You know, he would put her on hold. And that's when I had the opportunity to see her again and do my treatment. And during all this period of time, everything was halted. There was no more movement was done. So that's just to help you answer that question.
So you didn't, because I didn't really understand that if there is any lingual wall, or it's absolutely the root circumferentially only.
It was almost circumferential. So when I probed it at the time with my perio probe, it literally went through the lingual wall because it was all soft.
Yeah. So because, you know, you showed beautifully that with using the endogain, if I'm right, you had bone formation in the lingual part and a bit on the proximal, because here in the middle slide, I can see the mesial aspect of the adjacent root. So there is
Yes.
no bone. So the
No.
question for me is that where was the blood supply for that bone formation?
Excellent question. I love that question because a lot of the time when I showed this case, a lot of people asked me, is like, why didn't you add any bone graft? And my question to them was, where's the blood supply going to come from?
Yeah.
There's
Yeah.
no blood supply to the bone graft. So why am I risking by just thinking biologically, if there's no blood supply to the area, how am I going to add bone and expect that bone to regenerate predictably? You know, and what am I going to cover the bone with if I have no soft tissue to allow for proper wound closure?
Yeah.
You know, so what I believe is, again, this is an N of one because I've been treating cases like this, but they look very similar to the re-entry what I showed you. And I have about almost half a dozen cases that look exactly like the re-entry, where I'm going in, there's a small vertical defect, and I will add a bone graft and a connective tissue graft, and I will close it up. And that's what I've been doing, you know, for the early cases. But when it's this severe, this advanced, what I believe is the emdogain and the freegingival graft, I think the bone regeneration came from two areas. Number one could have come just from the periosteum of the lingual plates of the soft tissue. If there was any remaining, it might be very minimal, or it was possibly very thin. But what was interesting about this case, Omid, is radiographically, it looks like there's bone. Clinically, there was no bone, which was really what threw me off when I opened up the case, because I always look at the x-rays. And when I opened up, I was like, this makes no sense. I just took the PA, and the periapical shows very different what it shows clinically for something like this. So that's where I believe like the power of maybe the emdogain as a biological factor, which allows angiogenesis as well and cementogenesis. I believe that had a huge regenerative potential, and maybe adding the freegingival graft as an autogenous tissue material also possibly aided from just a genetic predisposition or a genetic component with the growth factors to aid in the wound healing process and allow that body to slowly regenerate the bone one more time. So it's a very interesting case. I've never seen anything from all my cases of GTR, and I do a lot of GTR. I do mostly teeth saving business. When I look at what we do mostly in our practice, it's mostly guided tissue regeneration. We're always in the mentality of saving teeth versus extracting and implants, because we can always extract, but patients like to save their own teeth, and that's our business for them.
Interesting thing that also I wanted to add was that because we talked about the blood supply and that there is no source, and also at the same time, utilizing the soft tissue graft on the root surface without having any bone behind it also can be a question that how that soft tissue graft will get the vascular supply to stay there.
Exactly.
And as you said, you predicted that it may not work, but it will get improved, and it actually happened. So I think in such scenarios, as you definitely said it, we should discuss it with the patient, because we cannot promise to the patient that what will happen if that tooth remain the same way when we remove the brackets, or if the bone will form. But at least we gave the patient a chance instead of extracting the teeth and go with the all on film and use
exactly.
Yeah.
Now what I do believe here, is some of that blood supply to the gingival graft came from the adjacent gingiva, from the adjacent soft tissue, because that's still intact blood supply. In other words, it might not be the most abundant, but it's still some form of nourishment to the graft that we added there. How much of that graft survived? Maybe 10% of it survived. Realistically speaking, based on the 6 month, 6 month post FGG, this is what it looks like. But this is the regeneration potential that we got at that time. So that means there was some form of blood supply that was able to reach the freegingival graft, preserve a little bit of it, and help and slowly aid in the wound healing process and the regeneration of that site. So again, what do I see most of the time for cases, anterior cases specifically on the two centrals? When I do a freegingival graft, it looks something like this. I'm aiming for a traditional graft, and I end up doing a GTR most of the time with a bone graft and a connective tissue graft. So we're changing our treatment philosophies a lot, and just to help in aiding in that regeneration potential for the patient as well.
And exactly. And one of the things that also we should think about is that before extracting the tooth, we should think that what can we give to the patient after extraction? Sometimes we can't do anything for the patient. Imagine if this case is in the anterior maxilla. I remember in the third symposium of complications, Marcus Herzler also presented the case in the central incisors with the same scenario. And imagine if you decide, okay, there is no bone, I will extract the teeth. Okay, you extract it, but is it possible to build up that bone again? And what will happen next? So it's, I think, so much thing to learn from this case. And regarding your third case, all of your cases were super amazing, and we can talk about all of them, but I want to keep it short. But in your third case, that you used like the Zucchelli technique and putting the connective tissue on top and the buccal aspect to build up the tissue. Actually, you mentioned the point that I want to make it clear now, but in this case, when we don't have any interproximal bone, and again, the concern is the vascular supply. Before starting this technique, did you predicted that the soft tissue gonna stay on that root surfaces?
Oh no. I told the patients, like, there's a good chance. Our goal is if I can get a little bit of vertical height, and I told you might require 2 procedures. That's the first thing I always tell my patients, especially in a case like this. So when I mentioned to her, I was like, if you're willing, we can always do 2 procedures, but the goal is let's start with 1. Let's see how it looks. I was like, you do have some severe bone loss. And just to give you a heads up, but this is all partial dissection. This was not full. So her bone level is actually much deeper than it actually is. So I was literally relying on the partial dissection of the area just to allow for my graft to survive. And I didn't want to compromise the bone healing and the implant healing that was underneath it. So everything was done 100% partial dissection. So I was honest with her. I told, we're going to try our best. Let's hope that we can gain some vertical height. Now, this being said, this was my first tabletop case that I ever did. I've never done one before. So I was trying to see, like, what can I do to really help this patient? And I explained to her, like, this is a very challenging case. We may get some good results. We may not. But at least it's going to be hopefully better than what you started with. So I always you have to always under promise and over deliver. So I was able to slightly over deliver, not significantly. I'm not telling you I'm Zucchelli. I'm not telling you I'm Ricardo Kern or those guys where they do some magnificent soft tissue work, but it was a little bit of improvement compared to what she started before. So that was kind of the result, again, at 4 months for this case.
Do you think that even with doing the second surgery, the situation around those exposed root surfaces would have been better?
It depends on the technique, Omid. I think if I had the opportunity to do it again, I might possibly choose a different surgical approach, number 1. Number 2, I might also consider at least having a Maryland bridge, so that way I would have some vertical suspensory sutures to allow to pull the tissue a little bit up and have a soft tissue graft underneath it, just to increase the soft tissue thickness. So like if you see the cases by Inaki Gambarina, who loves uses tuberosity grafts for a very extreme vertical, defects like these where he uses it. And actually, I had the opportunity to discuss this case with Inaki Gambarina. I sent him this case myself before I started it. And he said, does the patient have tuberosity? It's like, no, she has 0. And I was like, well, try, there's several ways you can do this. And he gave me some ideas. And I decided to go with the Zucchelli approach. So the question is, if I did what Gambarina had recommended, would have worked? Possibly, yes. But again, it was just one of those cases. Can you achieve some form of more vertical soft tissue height? Possibly you can. You just have to think more techniques needs to be done, adding other materials to your armamentarium to get it to the level you want it to achieve.
In this case, one of the things that I personally sometimes think about is that instead of doing the de-epithelialization on the palatal aspect, after doing the de-epithelialization, maybe it's better to reflect the palatal aspect to get a wall in a vertical and put a connective tissue graft and then bring the buccal flap and the palatal. So in that case, you have two sources of vascular supply from the inside and from the outside. So maybe it will enhance the vascular supply to your connective tissue on the top. So, and also you mentioned about the ortho helping improving the case. If the patient accepts, maybe forced eruption extrusion of the tooth can help also bring the tissue a bit down, but this is the patient choice because definitely it will need a restorative treatment afterward.
And it's not only that, but the patient already had the implant that was placed when I saw her. So if the implant wasn't there, ortho would be definitely 100% an option. The question then you start thinking, well, the implant is in. If I do ortho extrusion, where would the implant relationship be in relationship to the bone and all that? So you start thinking about all the other factors that can result later on from, possibly doing ortho extrusion or maybe ortho intrusion or some form of therapy just to improve the position of the CEJ in relationship to the adjacent teeth as well. So again, I was really hoping that she would go for orthodontic therapy, at least in some form, to improve the position of the bone, the CEJ. But again, she was, at this point, she's been through a lot. This has been maybe almost over a year, 2 years long process for her. She just wanted to get done. It's like, I'm tired, I'm done. I just want a tooth at this point in time. So you have to respect the patient's wishes. You want the best for them. But after so many surgical experience, they do get exhausted, I think emotionally and mentally as well.
Well, Fadi, I have to say it was one of the greatest discussions I've had during the 3 seasons of Teeth because, you chose the most proper cases that can bring so much questions and so much learning out of it. So I truly want to appreciate this selection and this presentation because I'm pretty sure all the audience have enjoyed it to the max. And I truly want to thank you for your time. I know your cases were super amazing. I know we can talk about it hours and hours, but I know the time is limited. So thank you so much again for accepting. Really looking forward to see you soon in person in Iran, the States, or anywhere else.
I look forward to it.
Yeah, so it was my pleasure and truly Hasan, thank you.
Have a great day, Omid. Stay safe, please.
You too. God bless you.